Well, I'm pleased today to talk about outpatient management of COVID-19. As opposed to a few months ago, we now have some good options for outpatient management. Please don't forget to register your attendance and claim credit. You can see here, if you're not already registered, text your email address to this number. And then once you've done that, text attend and the 8-digit activity code, which is right here, 100-89850, to that same number. If you have any issues or questions, please email us at cme@utesca.edu. Here are my disclosures, and as you'll note, this program is made possible by HHS, the Department of HHS. However, the contents are mine and do not represent official views of the U.S. government. Our learning objectives today are to name and compare 4 prescription medications that have emergency use authorization or FDA approval for treating outpatient COVID-19. And then, using available information, be able to select the best available medication to treat outpatient, that is mild or moderate COVID-19, for a patient depending on the patient's individual characteristics such as age, symptom duration, and comorbid conditions. Finally, identify at least 2 credible online resources for updated COVID-19 treatment guidelines. Okay, so first, let's talk about monoclonal antibodies. We've had these really since pretty early in the epidemic, and these have an emergency use authorization for early treatment. Previously, we used agents from Regeneron and Lilly. However, these do not have enough activity against the Omicron variant, which became prevalent in December 21 and January of 2022. So we began to use sotrovimab, which was active against the Omicron variant. However, now that we have an emerging Omicron variant called BA2, sotrovimab no longer has excellent activity against that. And so we will be using bebtelovimab. Right now, the BA2 Omicron variant is only about 11% across the US and probably around the range of 8% in our community. So we can still use sotrovimab, but as we get supply of bebtelovimab, we anticipate that our use will shift to that. So who should be treated with these? People with mild to moderate COVID disease, those who are at least 12 years old, and those at high risk of progression to severe COVID. And in fact, there are priority tiers by risk groups such as age, immune status, and clinical risk factors that you can find at this link by NIH. But basically, as we've known throughout the pandemic, those at high risk of progression to severe COVID-19 include those over 65, those who are obese, those who have diabetes, and other medical comorbidities, as well as those who are immunosuppressed. So there is now a pre-exposure prophylaxis emergency use authorization agent, and this is tixagevimab, silgavimab, or Evishield is the brand name. And this is a monoclonal with a long half-life, about 6-month half-life. It requires 2 intramuscular injections, and this is authorized for those who are immunocompromised that are expected not to respond fully to the vaccine, or those with a history of severe allergy to COVID-19 vaccine that were not able to get fully immunized. It is not a substitute. It's not authorized as a substitute for vaccination in those eligible, and Evishield can be received 2 weeks after vaccination. In terms of things to be careful about, it can cause hypersensitivity, including anaphylaxis, so it needs to be administered in a setting that can interact if that occurs. People with bleeding disorders need to be careful because it is an intramuscular injection, a fairly large intramuscular injection. And there have been some cardiovascular events in those with a prior history of cardiac disease. The supply is increasing. Initially, it was not readily available, but now there is a fair amount that's available, especially for the immunocompromised population. So let's talk about the oral antivirals, and our supplies of these are increasing. Nirmatrelvir ritonavir, or Paxlovid is the brand name. It showed an 88% decrease in hospitalization or death if given within 5 days of symptoms. And that's an important caveat to remember because often people will present much later than that. It has authorization for the treatment of mild to moderate disease in those 12 years of age and older who have a positive SARS-CoV-2 test and are at high risk of progression to severe COVID-19. Again, it needs to be started within 5 days of symptoms. Now, these two agents, this combination agent, nirmatrelvir, ritonavir, these are cytochrome P450 3A4 or CYP3A4 substrates. And so people that are on medications that are highly dependent on the CYP3A for clearance or for which elevated concentrations are associated with serious or life-threatening reactions, really can't take this without stopping those other medications. And so you can see the details on this with the EUA from the FDA, which is at this link. But to go over these established and potentially significant drug interactions, those drugs that are highly dependent on CYP3A here are listed here. And of note, the ones that may be commonly used, antiarrhythmics such as amiodarone, anti-gout medications such as colchicine, antipsychotics, the statins, which are very commonly used, of course, and in particular lovastatin and simvastatin. The PDE5 inhibitors such as sildenafil, this is only when used for taken regularly for pulmonary artery hypertension, that's a contraindication. And finally, sedatives and hypnotics, which are fairly commonly used, such as triazolam or oral midazolam, are also not ones that should be combined with Paxlovid. Now, because these agents are also substrates of CYP3A4, those medications that are potent CYP3A inducers, they would significantly reduce the concentration of these agents, and they may be associated with potential loss of virologic response and possibly resistance. So Paxlovid cannot be started immediately after discontinuation of any of the following medications because of the delayed offset of the recently discontinued inducer. And examples would be this anti-cancer drug, anticonvulsants such as carbamazepine, phenobarbital, phenytoin, antimicrobials such as rifampin, and herbal products such as St. John's wort, which is sometimes used for depression. Now, another antiviral is Monopyravir, and its supply is also increasing. Monopyravir has a mechanism of action of simply inserting itself into the RNA of the virus and causing mutation, and thereby limiting replication. And Monopyravir was shown to cause a 30% decrease in hospitalization and death, again, if given within 5 days of symptoms. It is authorized for the treatment of mild to moderate disease in 18 years of age and older. So note that this is different than Paxlovid because it can't be used in children. And you need to have a positive SARS-CoV test as well as high risk of progression to severe COVID-19 and should be started within 5 days of symptoms. Now, the warnings here is because it is a mutagen, there's potential embryo-fetal toxicity, so it's not recommended in pregnancy and not recommended in children due to the bone and cartilage toxicity. And you can read in detail all the caveats with this agent, again, at the EUA detail, which is found at this link. So what other oral treatments are options? Well, Fluvoxamine, or the brand name Luvox, it has been submitted for an emergency use authorization, but it's not yet authorized. It does have FDA approval for another indication, and that's for obsessive compulsive disorder. And it is a selective serotonin reuptake inhibitor, or an SSRI. And those agents, as you may know, are commonly used for depression. And why would this agent be active? Well, there's several proposed mechanisms. One is that because it activates the sigma-1 receptor, it reduces cytokine production. It also may inhibit sphingomyelinase, which is relevant for viral entry, and inhibits platelet and mast cell activity as well as metabolism of melatonin. So studies have been done, and two positive randomized controlled trials and a positive observational study have shown that it is associated with a 30% reduction in hospitalization or death, so about the same as Monopyravir. Studies are ongoing with this agent, and an advantage is that it's inexpensive and widely available. So early remdesivir in non-hospitalized patients has also emerged as an encouraging outpatient treatment. It has been shown to have an 87% reduction in hospitalizations or death if given as an IV infusion daily for 3 days. Now, obviously, as an outpatient, the logistics of this are currently difficult, because it must be given in a healthcare setting. It's an IV infusion. The patient has to come back for 3 infusions. But it can be considered in the setting where there is limited monoclonal antibody supply or oral antiviral supply. And it's especially considered in immunocompromised patients. It should be administered within 7 days of symptoms, and the article that outlines the use of this agent is found at this link in the New England Journal of Medicine. There are also still some studies going on, and this is an NIH multi-center outpatient study called the ACTIV-6 study. And if one is over 30 years of age or older, has a positive SARS-CoV test done within 10 days, and has at least 2 COVID-19 symptoms for 7 days or less, they can be a part of this study and can be randomized to a treatment arm, either fluvoxamine or placebo, or ivermectin versus placebo. This is a touchless study, which means that medications are shipped to the patient and there is remote monitoring. And if someone is interested in this study, they can go to this link, active6study.org, or call these phone numbers for further information. So, in summary, we have a number of options now for outpatient treatment. The nirmatrelvir, ritonavir, which is Paxlovid, the patient must not be on interacting medications, and the agent needs to be given as soon as possible or within 5 days of symptom onset. For the monoclonal antibody, and those agents keep changing, but right now, patient needs to, if a patient is on an interacting medication and are not able to take Paxlovid, and they're able to come to a healthcare facility or regional infusion center, they can be administered a monoclonal antibody. And this should be done as soon as possible after symptoms or within 10 days of symptom onset. Remdesivir in the outpatient setting can be given in a healthcare facility or through a home infusion service, should be given as soon as possible after onset of symptoms and within 7 days of symptom onset. And finally, Monopyravir, if the patient is not able to be treated with one of the options above, is not pregnant, is not a child, they may be given this agent and should be given as soon as possible and within 5 days of symptom onset. So these are the agents that either have an EUA or FDA approval, and I also mentioned fluvoxamine, but it's not listed here, but it's also a potential other option. So here, if you're interested in finding out, are these agents available in my area? And certainly they are much more available now than they were early during the surge. You can go to this HHS COVID-19 Therapeutics Locator, and that's at this link here, or if you just Google HHS COVID-19 Therapeutics Locator, this link will come up. And you can put in your location, and it will tell you how much of the agents are available in your area. As you notice, we have a fair amount of Evusheld now, a lot of Monopyravir, and a fair amount of Paxlovid. We do not have bebtelovimab available right now, at least as a couple of days ago. Sotrovimab is still available. So you can also find on here the specific pharmacies that have the agents, and those are listed on this site as well. And finally, if you are interested in the details regarding outpatient treatment, there are a number of resources online, the NIH guidelines, the IDSA or Infectious Disease Society of America guidelines, and you can find these just by Googling COVID treatment guidelines, and these will pop up. And also strac.org, which is our regional center that deals with emergency preparedness, has some outpatient strategies by our local infectious disease leads, which can also be of help. And you'll find that at the strac.org website. So we have time now for some questions.